Hi, this is Zach Fulkerson with the Critical Care Curriculum, and in the second ventilator lecture, we are going to be discussing modes of ventilation. This is a particularly confusing topic because ventilators use lots of different letters and they vary from company to company. Our main goal is to just try to simplify this, to discuss the different types of ventilator modes, maybe what a mandatory breath is, what a spontaneous breath is, and how to make sense of all these letters that the ventilator gives us. Quick note, ventilators are positive pressure, and so we have a lot of control over inspiration, how long the breath is, how big the breath is, but all expiration is passive. So we really don't have much control over expiration, with the exception of maybe how long the patient is allowed for expiration. First thing that we set when we're thinking about a ventilator is what our target is. We can target either a pressure or we can target a volume. We can say, I want this patient to get 10 centimeters of water worth of pressure or 15 centimeters of water worth of pressure. Or we could say, I want the patient to get 400 milliliters of volume worth of pressure for every single breath. We really don't have a whole lot of choices in terms of targets aside from pressure or volume. Beyond the breath target, we can decide on the type of breath that we allow. There are two main flavors. There's mandatory and there's spontaneous, and these differ by how much control the patient has. So in a mandatory breath, either the ventilator or the patient can initiate the breath, but the ventilator controls how long the breath is. Whereas in a spontaneous breath, the patient controls how long the breath is. So here the vent is controlling it, the inspiratory time or the I time, and here the patient is controlling that. There are two different subtypes of mandatory breaths. We have control breaths and assisted breaths. Control breaths are basically breaths that are initiated by the ventilator. So for instance, if you set a respiratory rate of 12 breaths per minute, then the ventilator is going to give at least one breath every 6 seconds, whether the patient is initiating a breath or not. An assisted breath is basically the patient initiates it, the ventilator recognizes the patient initiating the breath, and the ventilator gives the patient a full mandatory breath. Every breath in spontaneous mode is initiated by the patient. Now, the next thing that we look at is the breath sequence. So we have, and this is basically what types of breaths that we allow. So we have on one end of the spectrum, continuous mandatory ventilation. This is where we only allow mandatory breaths. This is often called control mode or assist control mode. So for instance, the patient can have assisted breaths or control breaths, but these are all different types of mandatory breaths. And then on the other end of the spectrum, we have continuous spontaneous ventilation. You'll hear this called just simply spontaneous mode or support mode. And in between, we have this weird thing called intermittent mandatory ventilation. Sometimes you'll hear it called synchronized intermittent mandatory ventilation, or SIMV. So our mode is simply the target, so either volume or pressure, plus the sequence, which is going to be that continuous mandatory ventilation, CMV or CSV, and then this weird thing called target scheme, which is really beyond the scope of what this lecture is going to get into. So for instance, a mode could be a volume control, so a volume target plus, say, a continuous mandatory ventilation, and that would give us our mode, volume control, continuous mandatory ventilation. Okay, let's look at some examples of these. First, we have volume control, continuous mandatory ventilation, and on this graph, I have time in seconds down here on the x-axis, and on the y-axis, we have flow, pressure, and volume. Inspiratory flow is positive, expiratory flow is negative. Remember, I can control how long the inspiratory breath is in a mandatory breath, which is what this is. This is continuous mandatory ventilation. So I am dictating how long this breath is. And this breath is the exact same length as this breath. In volume control, I am saying that the patient is going to get a certain volume, say 400 milliliters or 450 milliliters, regardless of what the patient is doing. And so I'm going to give them a certain amount of pressure, so a little bit of pressure to overcome the resistance of the tube and the airways, and then any more pressure that I need to get me this volume. But I'm always going to go after a certain volume that's dictated right here. Here we have an example of a control breath. So this is initiated by the ventilator, and this breath is initiated by the patient. How do I know it's initiated by the patient? Because of this little dip in pressure here. This is called a trigger. The patient is making an inspiratory effort. So when they make an inspiratory effort, the pressure in the thoracic cavity goes down. The ventilator senses that and gives them a full breath at the volume that we give them. So this is what volume control continuous mandatory ventilation looks like if you're looking at the waveforms on your ventilator. Other names that you're going to see is assist control, volume control, or you may just see this called volume control. There are some advantages in that you have a consistent volume that's always being given to the patient for every breath, and you have a definite minimum minute ventilation. So you know that you're going to have a minimum of a certain number of liters per minute that the patient is getting. Disadvantages is one, it's not very comfortable. It's not a very natural way to breathe. And two, if the patient has really poor lung compliance, you may need a lot of pressure to get this volume. So you could actually give your patient something called barotrauma just because you're having to give them so much pressure to get a certain volume. All right, so if this is volume control, where we're giving a patient a certain amount of flow to achieve a certain volume, pressure control is where we're not targeting volume, but we're targeting a pressure. So here, I'm targeting a pressure. The ventilator quickly goes up to a pressure, and it holds it for as long as I say hold. And again, that's called the inspiratory time or the I time. This is called pressure control, which is what our breath target is, continuous mandatory ventilation. So every breath is still mandatory. There's nothing spontaneous here. This is a control breath because the ventilator is initiating the breath. This is an assisted breath because notice here we have an inspiratory effort. Notice that my volumes can actually change breath to breath depending on how engaged my patient is, if they're making an inspiratory effort when the machine's going off, and depending on their compliance. Other names that you're going to see for this is called assist control, pressure control. You're going to hear this also just simply called pressure control. Advantages are it's a little bit more comfortable than volume control. It helps to avoid barotrauma. But the disadvantages are the variable tidal volume and the variable minute ventilation. It's really hard to know how much minute ventilation your patient is going to get, especially if they have conditions where their compliance is changing, say developing pulmonary edema or developing ARDS. That would cause a worsening of lung compliance to where their volumes could get really, really small if you're giving them the same pressure over and over. You can get over distension or volutrauma. If someone has exceptionally compliant lungs, you could actually give them incredibly large breaths with that. So this is pressure control, continuous mandatory ventilation. I want you to notice the waveform of the pressure here because our next mode is going to be this adaptive mode, and it's called volume control, continuous mandatory ventilation. And we're targeting a volume, but notice that the pressure waveforms are plateauing and they look a lot more like pressure control. So what's going on here is this is at its root a pressure control mode, but we're going back and we're taking, say, a moving average of like the last 3 or 4 breaths, and we're trying to figure out how much pressure to give the patient based on that moving average of the last several breaths. So say the last breath, the ventilator said, oh, I didn't quite hit my target with this pressure target. I'm going to try to increase the amount of pressure, and oh, here I overshot it, so I'm going to decrease it, and the ventilator keeps going up and down with the pressure until it settles in on whatever your target volume is. So you're actually setting the volume, but internally the ventilator is actually targeting pressure. It's a little bit of a confusing topic, but it's one worth getting to know because this is actually probably the most common ventilator mode that we use in the adult ICU. Now, you might see this called PRVC or pressure regulated volume control. You might hear this called ACVC plus or assist controlled volume control plus, depending on the type of ventilator. The advantages are, of course, the consistent minute ventilation and the patient comfort. So we're kind of getting the best of both worlds. I think the disadvantages are really that it requires patient synchrony. So if you have a patient who's making a huge inspiratory effort on one and then maybe expiring during another breath, this could be all over the place. So you really need a patient who is synchronous with the ventilator in order for this to work. If you're having trouble with this mode, the easiest way of fixing it is probably to go to a simpler mode. But again, you're going to see these modes, ACVC plus, PRVC, a lot in our adult ICUs. Next, we have spontaneous mode. So we have pressure controlled continuous spontaneous ventilation. And notice the flow pattern is a lot different than what we had before. So the patient is actually generating all of the flow. The ventilator is basically giving a certain amount of pressure support, and every breath is initiated by the patient. The tidal volumes can change depending on how much effort the patient is making, and the flows change depending on how much effort the patient is making. As I said before, the patient controls how long the breath is. So you might have a long breath and a short breath, and essentially at some point when the flow goes down, when the ventilator will sense that the patient is starting to end their breath, and they'll just stop it once they sense that the patient is kind of ending the breath. So other names, we call this pressure support. We call it spontaneous mode. You'll sometimes hear this called CPAP as well. The advantages are, of course, the patient is engaged and initiates all the breath, and we tend to use this when we're thinking about taking the patient off the ventilator. So let's say that whatever reason the patient needed to be intubated in the first place, that's resolved, so we're trying to give them a dry run of breathing on their own, and so we'll use this as a weaning mode. The disadvantages is, of course, there's no minimum minute ventilation. And if the patient becomes apneic, a backup mode usually kicks in. All right, so that's continuous mandatory ventilation, continuous spontaneous ventilation. There's this weird thing in the middle called intermittent mandatory ventilation, or SIMV. Basically, it's a combo of control breaths and spontaneous breaths. We don't use them in the ICUs very often, so I'm not going to go into it any more than that. I just want you to know that it does exist. In the adult medical ICU, we generally use continuous mandatory ventilation, especially that volume control, that adaptive volume control that I was telling you about before, for most of our general purpose ventilation. For weaning, we tend to use spontaneous modes to see how the patient does on their own before extubating them. There are other more advanced modes that we're not going to go into. I just wanted you to have a quick background of what sort of lingo you're going to be seeing when you're seeing patients on the ventilator in the ICU. And that does it for this second lecture in mechanical ventilation.